Hey guys, hey family, hey friends. I hope you guys are doing great. This is Dr. T, and this is Clinical Medicine with Dr. T. And I welcome you to today's episode of a patient that I saw. So, guys, the patient that we're going to talk about today, you know, we're not going to talk much about the management, but there's something that I want to show you this patient, something interesting. The reason why I'm not going to talk much about the management is because I handed the patient over to internal medicine and then they accepted the patient. So they took over the care of the patient. So this is the patient that I saw on Friday morning. So what happens is when I'm working during the day, which is casualty, where we see medical emergencies. This patient, so what happens there is that the doctor who sees the patients at night, if there is maybe bloods that are still, if there are bloods that are still being done, so the patient is waiting for bloods. So when we come in the morning, we see those patients because some of them, the doctor who's working the night cannot really make a decision without the blood, and the labs, the lab results, they do take long. So when we come in the morning, we see the new patients and we also see reviews from the previous night. So the patient I'm going to tell you about now is a patient that was seen on Thursday by the night doctor, and I reviewed this patient the following day. So it's a 29-year-old female patient. 29-year-old female patient. So this is how this is how we write in casualty, right? It's not a way that you guys should be writing at this point, especially if you're a student, but this is how we write in casualty. So when we see a medical patient, we want to know first the medical history before they tell us about what's happening. So that's what we write. So the first thing there, this patient is RVD positive since 2015, and she's taking efavirenz, TDF and FTC. This is the regimen that this lady is on. So I couldn't find any recent CD4 count or viral load. Because sometimes it's nice to also just put it there as well. So then the other thing that she was on TB treatment. When you see a patient who's taking TB treatment, so you need to ask what kind of TB do they have, and how was it diagnosed. So she was as much as she was very sick, but she was a very clever lady, because she told me that the diagnosis was made through or by a ULM. So that was October 2021. Sorry, 2020, last year. October last year. So she's been on she's on refiner right now. So when a patient says, I'm taking TB treatment, you should ask them what kind of TB were they told to be having and how was it diagnosed. Some will tell, okay, it was a chest x-ray. Some will say it was a gene expect. Some will say it was a AFB, acid fast bacilli. Some will say it was a ULM. So a ULM is a urinary test that you do. You take, the patient gives you a sample of urine, you do a test. It's like there's a small, it's like a small device, like a disc. You just like a pregnancy test, you drop a few drops of blood there, then it gives you two lines. Does it give you two lines? Actually, I need to verify that. I think it gives you one line. So if there is no line, it's a negative. If there is a line, then it's a positive. So it doesn't have a second line where there's a control and all of that. Yeah. And now I remember. So that's a ULEM. So a ULEM, it tells you about extrapulmonary TB. So it's not very good for pulmonary TB. It tells you about extrapulmonary, but still it doesn't tell you if it's the TB of the intestines, if it's TB of the stomach, if it's the TB of that, or just lymph node. It doesn't tell you that. It just tells you that the patient has got extrapulmonary TB. And also, you need to do this on a patient who's got a CD4 count of less than 100. The results are not really reliable for someone who's got a CD4 count of more than 100. So those are the things. So it's a ULAM, it's a urinary test, or it's a urine test. So obviously she was taking this and the pyridoxine, and some painkillers. She was also on trophyline and all of that. So now the problem. So when I looked at the previous the notes from the previous doctor, so this lady was assessed as oral candidiasis. So remember, oral candidiasis, candidiasis. Oral candidiasis is a fungal infection. It's one of the opportunistic infections of someone who's got immunosuppression. And remember, immunosuppression is not only HIV. Chemo drugs, radiation, these things they do cause, and steroids, they do cause the patient to have suppressed immunity, and also some inherited disorders and things like that. Even a splenectomy does give you some form of immunosuppression. So yeah. So the pathogen there for oral candidiasis is Candida albicans. Candida albicans. So that's the assessment, and then she also thought that she might be having renal failure, renal impairment. That's what she wrote, renal impairment. I don't know why my spelling becomes bad when I'm teaching. I don't know why. Okay, so renal impairment. So this is with the differentials of the doctor who saw the patient, and then took the bloods, and then she was waiting for bloods now. So now my job was to, when I review a patient, it's always a good practice to go back to the history and ask the patient questions again, and also see if there's something that you can add, if there's something that maybe you can, that wasn't written, something that you can just pick up, and all of that. So so I went back to the history. So the complaint, according to her, was that she was having loss of energy, she was having whole body swelling, and the medical term for a whole body swelling is anasaka, right? And then she was also vomiting, but it was not it was just on and off. She was not having any diarrhea, no diarrhea. What else? So she was having pain on swallowing. She also complained swallowing. She also complained that she had also some sores around the perineum. So okay, fine. So I examined her. So these were the things that I picked up on the So the first thing, the vital signs. On examination, she was she looked very weak. She looked very weak. She looked chronically ill. She also looked in a bit of distress. So her blood pressure was 93/67. Her pulse was 114, and the headsets were 94 on room A. 94 on room A. And her respiratory rate was 40. So it's always nice to be that doctor who sees the patient when all the results are there, when all the blood results. It makes your life easier. It makes it easy for you to make the diagnosis. It makes it easy for you to start the management and talk to the relevant disciplines. So I was fortunate that almost everything was done for this patient by the previous doctor. So so now I looked at her and I saw these. So already you can appreciate the fact that this lady had hypertension. So she had hypertension. She also had a tachycardia. She was also tachypneic. You see? So this patient was hemodynamically unstable. So this is an unstable patient. As much as she was sitting there with the GCS of 15 and talking, but she was talking with effort, né? 15/15. So I looked at the chest. I didn't pick up anything on the chest. I examined the chest, didn't pick up anything. CVS, I didn't pick up anything. One thing that stood out was facial swelling, né? Facial swelling. Her face was swollen, and the abdomen, there wasn't much that I also picked up. And then, but there, when I did the MSS, she had like severe pitting edema. She had severe pitting edema that was up to the knees. Oh, one other thing that I also forgot then is she was slightly pale as well. She was pale, just slightly, very slightly. So fine. So, and then now, after that, I looked at the blood results because I wanted to look at the blood results and compare with this picture what is happening here. So I wrote the blood results. I'm just gonna quickly write the blood results here. So these are the blood results that the other doctor was waiting for. So her blood results, she had a CRP of 254. For those who don't know what a CRP is an inflammatory marker, just like ESR. Normal should be around 10. It's around 10. So once you have a CRP that is that high, this patient has got infection plus minus inflammation. I've seen conditions. That's what I'm saying plus minus. I've seen conditions or patients who's got a high CRP but they've got no infection. Just remember that any inflammatory process will give you a high CRP. Like patients with osteoarthritis, patient who has got any kind of arthritis, even SLE, those patients will have a high CRP even though they don't have an infection. But when you have got a CRP that is high plus a white cell count that is also high, hers was like 20,41. That's hers. So what I'm trying to say here is that you can have a CRP that is high without infection, especially if your white cell count is normal. But here we've got both of these being high. If someone has got a healing wound from whatever surgery, they will have a high CRP because there's an inflammatory process that is happening around on the wound, not necessarily that they've got an infection. So just remember that it's an inflammatory marker, not really an infective marker. But if you've got a CRP that is high plus a white cell count that is high, then this is an infection picture. Okay. Because I'm trying to avoid having someone who's got a high CRP and then you keep them in the hospital and put them on antibiotics, and then you don't find the cause of the CRP that is high, the inflammatory process that is happening in the patient. Okay, one other thing that so please go and watch a video on approach to FBC that I have on this channel. So she had a HB of 8.5, which is low, right? Which explained why she was slightly pale. And then the next thing that I looked at was the MCV. The MCV was 87. So based on this patient had a normocytic anemia. So she had a leukocytosis. She had a normocytic anemia because the MCV was normal at 87, and also, okay, so our doctor there saw the patient that was having swelling of the face, swelling of the legs, and she thought maybe this patient is having a renal impairment. So one of the things that I had to look at is the urea and the creatinine. I was so happy that the urea was fine and the creatinine was also fine. So she didn't have any renal problems because her urea was 5.5. We start thinking about renal problems, renal impairment, renal failure if this thing is above 10. And then the creatinine, her creatinine was 39. And I'll explain why it was 39. It's low, right? I'll tell you why it was low. So with this kind of a picture, this patient was not having any renal impairment. Yes, clinically, if a patient has got periorbital swelling, swelling of the face, swelling of the legs, you are justified to have one of your differentials as renal impairment or renal failure. But these were fine. Also, they also did a GFR, which was more than 60. So this guy now was out. So the next thing, the other bloods that were there, okay, they did a potassium, which was also normal. So let me not talk about the normal readings, right? Or biochemical markers. So this is where the problem was now. Her total protein was low. Total protein. Her total protein was 47, and the normal for her is 60 to 78. So this, and then now, when you look at the total protein, whether it's high or low, look at the albumin now to see what's happening with the albumin. Her albumin was 10, and the normal is 35 to 52, right? So the things that were abnormal for this patient that I want you guys to look at is this is low, but it doesn't bother us. We know why it's low. A low creatinine is not an issue. Kids have got small body size, they've got a low creatinine. Someone who's wasted, they get a low, because their muscles, they become small and stuff, so they've got a low creatinine as well. But what was outstanding in the results is this. So this patient had a severe hypoalbuminemia on top of having a low protein. So the low protein that she was having was because of this albumin. And we know that she also had a normocytic anemia as well. She had a leukocytosis. She had an elevated CRP. So we know that this patient has an infection has got hemolytic anemia, has got severe albumin. Okay, now the next thing that I did when I saw this albumin, I had now to decide, is this what's happening with that albumin? How and why is she losing the albumin? So the next thing I did a urine dipstick to check for protein. She had a 3+ protein, guys. So the dipstick, this I did myself. So she had a protein of 3+. So the diagnosis at this point that I had was a nephrotic syndrome. The protein had no blood. Remember, if you have got proteinuria and you have got blood, that's a nephritic syndrome. But if you have got proteinuria plus without blood, that's nephrotic. And also the amount of protein also tells you if it's nephritic or nephrotic. I'm going to talk about nephrotic versus nephritic in one of my next videos. That's why we're going to talk about the management of these kind of patients deeply. Okay, so my diagnosis at this point was nephrotic syndrome. Nephrotic syndrome. Okay guys, what I want to do now, I will upload this part and then I will do part 2 of this, because I don't want us to have long videos. Let's meet in part 2 of this. Thank you so much for watching. Thank you for supporting. Love you so much. Bye.